Hello, my name is Michi Shinohara, and I am at the University of Washington and the Fred Hutchinson Cancer Center, where I'm one of the directors of the Cutaneous Lymphoma Clinic. And I'm going to talk to you today about quality of life and cutaneous lymphoma. These are my disclosures. I get some research funding from Kyowa Kirin to support a fellow, and then I'm on the National Comprehensive Cancer Network panel for T-cell lymphomas. Not going to be relevant to this talk. I want to define some terms. First is patient-reported outcome measure. This is really anything that can be reported by a patient rather than being measured or observed by others. For example, itching, pain, satisfaction with treatment. Those are all examples of patient-reported outcomes. I can't measure that. Health-related quality of life is another term I'm going to use pretty frequently in this talk, and that really refers to all health-related aspects that contribute to a person's quality of life. This is the Wilson and Cleary conceptual model of health-related quality of life, and it really just emphasizes the fact that there are multiple components and contributors to overall quality of life. Health, how you interpret that health, the impact of the health on your functional status, your ability to work. All of these things contribute to overall quality of life. Cutaneous T-cell lymphoma, or CTCL in particular, is a disease that really highlights the importance of patient-reported outcome measures. In the ideal world, we would have a treatment that cures cutaneous lymphoma, is extremely well tolerated, no side effects. However, that does not exist yet. Hopefully, we'll get there. What we have instead is this paradox where we have treatments that are very powerful, can induce a complete response or CR, but they tend to be very short-lived and they are very poorly tolerated. An example would be traditional chemotherapy. On the other end, we have treatments that can have some impact. They can have partial responses or PRs that are sometimes durable, last a while, and they may or may not improve quality of life. And the inverse can be true. We can have a treatment that is well tolerated, but does not have as large of an impact. So we have this paradox. Why else should we care about quality of life? Well, one really critical reason is that it's important to drug development. This is from the 21st Century Cures Act, passed in 2016. And in this act, the FDA modified its drug approval process. While the primary purpose of this was to expedite the approval of new drugs and medical devices, this modification also emphasized the importance of incorporating the patient's voice during the drug development process. Patient experience data needs to be included. What they didn't do was explain how this data should be incorporated. We know that patients with cutaneous T-cell lymphoma are impacted with their quality of life. This is Marie-France Demier. She was one of the pioneers of studying quality of life. She was one of the first to show that patients with cutaneous T-cell lymphoma experience a really significant impact on health-related quality of life across all domains: emotional, functional, psychosocial. And it's disease stage related. So patients with more advanced stages experience greater impact. Another thing that became clear in this initial study was that even among patients with early stage disease, early stage mycosis fungoides, 80% were worried about dying. So that's really significant impact on people's mental health, emotional health. Since those studies in the early 2000s, unfortunately, we've had lots of new treatments, which is great, but health-related quality of life does not appear to have improved much. We essentially repeated this study by Marie-France in the early 2020s, looking at a cross-sectional survey of over 300 patients with cutaneous T-cell lymphoma, self-identified. And in this study, we found that patients with cutaneous T-cell lymphoma reported health-related quality of life, which was equivalent to patients with other cancers with what's called an ECOG score. ECOG is a Eastern Cooperative Oncology Performance status. It's basically a measure of how functional someone is. And category of 2 is equivalent to requiring bed rest for a good portion of the waking day. So patients reported that their quality of life was equivalent to someone who's capable of self-care but unable to work, requiring some bed rest. We found that there were some predictors of people experiencing worse quality of life. Similar to previous studies, we found that if you had a higher stage, your quality of life is likely worse, or if you had involvement of your disease on the head and neck, acral, meaning hands or feet, or genital involvement, that you likely had worse quality of life. The time spent caring for your cutaneous lymphoma was also related to your quality of life. A quarter of the patients in our study reported spending more than 60 minutes daily caring for their skin, which is really significant. And then we found patients with this higher burden score also experiencing worse quality of life. And these questions were modified from Marie-France Demier's original study. And they're really questions that address possible stigma or shame associated with cutaneous T-cell lymphoma, such as needing to keep the condition private, feeling like you've been treated unfairly because of it. And we found that the impact of this burden score was really significant and on par with the impact of stage. There's other data that support some factors associating with worse quality of life. This is from the ProClippi study. The ProClippi study is a very large prospective, that's the pro component of ProClippi. Prospective meaning forward-moving, nicely kept database of patients with cutaneous lymphoma. And in this study, the investigators looked at a couple hundred patients with mycosis fungoides, including about 180 with early mycosis fungoides, and found that some factors that were associated with worse quality of life, in addition to stage, which we already knew, were female gender and alopecia. We've also looked at what other things can be associated with quality of life. A significant number of patients in a survey study that we performed reported using a complementary alternative medicines, integrative medicines, to both treat their symptoms, which is what I thought patients would report, but a not insubstantial proportion of people, 48% of people who responded, reported using these integrative medicine techniques to actually treat their lymphoma. We also found in this study that those who reported using integrative medicine reported worse health-related quality of life across all domains. And you might hear that and think, well, that means I shouldn't use these techniques. I actually think that what this means is that people who were experiencing worse suffering were seeking out more ways to alleviate that suffering because we weren't doing a good enough job. So that's a significant relationship. We've also looked at cannabis use among patients with cutaneous lymphoma. Cannabis, as we know, is legal in many states. And in this study, we surveyed about 120 patients and asked them if they'd ever used cannabis and for what purpose. We found that 22% of respondents reported currently using cannabis. This is in Washington State, where cannabis is legal. Interestingly, half of those patients reported starting it after their diagnosis, and the majority were not telling their providers about their cannabis use. Reasons reported for using cannabis included using it to alleviate anxiety, pain, stress, and itching. And what we took from the study was that patients are very interested in learning about cannabis. They also want to hear about it from their providers. Problem with that is that a lot of us are not very educated in cannabis and cannabinoids. So, knowing that our patients are really seeking this information, it's important for our providers to learn something about this. So we have what's called an endocannabinoid system. This is how cannabis works on our brains. We have cannabinoid receptors, which is one of the compounds in cannabis present in our brain. But it turns out we also have cannabinoid receptors distributed widespread throughout the body, including in the skin. So there are really significant barriers to data, to doing significantly research about examining cannabinoids. My understanding is that cannabinoids cannabis are Schedule I substances in the US, which are akin to heroin and amphetamines. That there is a single source of cannabis that can be used for research. Apparently, it comes from the University of Mississippi, and it's of lower potency than what a lot is commercially available. So there is a lot more use than data at this point. Hopefully, this will change. But there is, despite these limitations, some studies that have been performed looking at the impact of cannabis and cutaneous lymphoma. There was a study that looked at cell extracts, ex vivo, so cells taken from patients with mycosis fungoides or Sézary and exposed to cannabis extracts. And in this study, the investigators found that that there was actually some activity by cannabis extracts against the mycosis fungoides and Sézary cell lines that was actually relatively potent and effective at killing these tumor cells, but it was only certain combinations of the extracts. So there are like 120 different cannabinoids present in cannabis, and it was only specific combinations that were effective. So definitely more work is necessary. So knowing this, how do I counsel my patients about cannabis? I tell patients, and this is, based on what I know from patients telling me and what I know in the literature, that they may be helpful with pain, insomnia, and itching. I don't think we really know whether cannabis products themselves are active against the cancer itself, but I no longer think it's totally outside of the realm of possibility that they might be. I do think it's really critically important to keep the team informed if there's any cannabis use. And really critically, I tell my patients, do not smoke or vape cannabis products. The reason I became interested in looking at cannabis was because of a study that was done at my institution by one of my colleagues in infectious disease, who did a study looking at, this is Steve Pergam, did a study looking at the incidence of cannabis use among all patients walking in the door at our cancer center. And the reason he was interested in this as an infectious disease doctor was because he was seeing a high incidence of unusual fungal infections in patients who were very immunosuppressed. And his suspicion was that this was related to cannabis use. And he did confirm that patients who are smoking cannabis are at higher and then become immunosuppressed or at higher risk of developing significant fungal infections. So I tell my patients, no smoking or vaping, because that's one thing that we know has a safety concern. Okay, one message I hear at this point from many patients is, thanks for telling me about what I already knew, that I am impacted by my disease. What are you going to do about it? And I hear you. I think this is a really important message. For me, one thing is you can't fix something you can't measure. So we got to get our data straight. One principle that many in the field of cutaneous lymphoma have relied on is that the best way to fix quality of life is to treat the lymphoma. Of course, that's the best way to do it. However, we know we can't cure cutaneous lymphoma, most kinds, at this point. So what are we going to do in the meantime? What can we do to improve quality of life? So we can't change it until we measure it properly. We need to define and agree upon the best way to measure quality of life and continue to measure it. And then because we can't cure cutaneous lymphoma, I like to talk about addressing everything but. Of course, we're going to still address the lymphoma as best we can, but what else can we do? Towards that question of measuring quality of life, an issue we have in the field right now is that there are numerous ways that we have tried to do this. There is, something like 30 different ways to measure it in different studies. None of them are agreed upon, and we need to get our story straight. I'm part of this group called IDEOM. It's International Dermatology Outcome Measures. It's a group, multidisciplinary. In my subgroup, we're cutaneous lymphoma. We have oncologists. We have dermatologists. And the goal is to really clean up the process of how we measure patient-reported outcome measures. We collaborate very closely with industry, so drug developers, in order to really define these the best way for studies and for clinical practice. This is our current work group. And the core purpose of this group is to maximize the care for patients with cutaneous T-cell lymphoma by determining the most ideal way or ways to measure patient-reported outcome measures or patient-reported outcomes. We have an ecosystem, which is centered on patients, patient representative. We have CTCL experts. We have members from the industry. And then we have the other IDEOM work groups and ecosystem to support us. Key questions that we're trying to answer is, what is the best way to measure health-related quality of life in cutaneous T-cell lymphoma? And we want to do this by filling the gap in existing literature around health-related quality of life, particularly patients who are currently underrepresented in the literature, such as patients with skin of color. And then we want to perform content validity studies to look and see, are the things we're commonly using right now the right things to be using? Going back to very basic things like, how do we measure itch? Okay, and then pivoting just a little bit to talking about talking about addressing everything but. I get this complaint a lot when I lecture about burnout to my faculty and residents. The cure for burnout is not to do a lot of yoga. It's not to meditate. It is to fix the systematic issues that are driving burnout. Similarly, in cutaneous lymphoma, in many diseases, the cure is not to suggest to do mindfulness and yoga and to tell patients to deal with it better. The fix is to actually fix the disease. And if somebody is drowning, you don't say, hang on, we're building a new ship. I'll get to you when it's done. You throw them a life raft. So I want to try to convince you that even though we do not yet have a cure for cutaneous lymphoma, there are things that people can do to improve their quality of life. And we as a system can support that too. So when I say addressing everything but, I'm really talking about addressing mental health and providing psychosocial support, mindfulness-based interventions, and then potentially examining alternative regimens for managing pain and itch. We know that patients who have cutaneous lymphoma and experience any mental health conditions, depression, anxiety, have a substantially deeper impact on their quality of life. So it is critically important to screen for depression, anxiety, and to offer treatment if either are found. I am not saying that doing these will fix somebody's cutaneous lymphoma, but patients' experience of their cutaneous lymphoma is worse if there's also depression and anxiety present. So very important that those are detected and addressed. If you are experiencing symptoms of that you bring it up to your providers, ask for help. Those things will help you deal with your cutaneous lymphoma better. They'll help you deal with their treatments better. Patients, are usually handle, more complex treatment regimens better when they're not, we're dealing with sort of muddled thinking from feeling depression, when they're able to sleep better. So critically important. Another concept that I want to talk about is mindfulness-based intervention. So mindfulness is this principle. It's a state of being present in the moment without worrying about the future or ruminating in the past. And this concept of mindfulness was born from John Kabat-Zinn in this book, Full Catastrophe Living. John Kabat-Zinn is a professor at the University of Massachusetts, originally trained as a microbiologist. But he developed this program, which was rooted in Buddhist principles, but is itself a secular, non-religious program. And basically, mindfulness-based interventions are structured courses that people can go through. Many physicians, many medical providers do them, and there's more and more data about the impact of these programs on patients as well. Mindfulness-based stress reduction programs can decrease psychological distress. They can decrease the morning cortisol, which is a stress hormone. They can increase empathy, so they're often like prescribed for burnout. And the results after somebody completes one of these courses can be sustained for months. Mindfulness-based interventions have been studied in the setting of cancer, where they've been shown also to reduce depression and anxiety and improve coping ability. So, mindfulness does not have to equal meditation. There are other ways that mindfulness can be incorporated. This is how I incorporate mindfulness as small snippets in my daily life. Things like mindful walking, feeling the ground under your feet, even mindful, daily tasks like toothbrushing. When was the last time you paid attention when you brushed your teeth? Eating something mindfully rather than just scarfing it down, even like experiencing something mindfully pleasant or unpleasant through other senses. So mindful moments can have similar impacts to meditation. So, in summary, we are working on ways to reach consensus about how and what to measure in quality of life for patients with cutaneous lymphoma. Of course, the best way is to cure the lymphoma. And until we get there, we must do other things, such as address mental health. And there's good evidence in other cancers for mindfulness-based interventions. And I strongly encourage anyone, provider or patient or family member, to consider exploring one of those. And I really thank you for your attention.